Welcome to the view from the Thoraxcenter for Radcliffe Cardiology. I am Nicolas from Mieghem, Joost, Daemen, my good friend and colleague as always. This time we are wrapping up the ACC 2025 meeting at Chicago. Maybe, Joost, we can start with a structural trial.
Yeah.
And this was one that was highly anticipated, the British Heart Foundation Protect TAVI trial. Raj Karbanda presented the data for the first time. Quite a large trial, more than 7,600 patients were randomized from 33 sites in the UK. They were randomized to either sentinel filter-based embolic protection or no protection during TAVI. The trial was prematurely stopped by the DSMB and there were some concerns about efficacy and questionable safety. Approximately 30% of the patients that were treated for TAVI in these sites were enrolled in the study. So by no means this is an all-comers trial. So that is very important. And also what I thought was striking that it was there was only an 80% success rate in the deployment of the filters. So that raises also some questions about the expertise, the skill set, how do you want to call it? But I was a little bit surprised by that high number. Yeah. And patient selection, obviously. You need to select the proper patients based on CT guidance, and that was not really happening. So patients with also complex anatomies were considered for the trial, but then you end up with a potpourri, a mixture of patient phenotypes. So the question there is the generalizability. That said, the mean age of the patients was 81 years old, 39% were women. The Euroscore 2 was 2.4%. So we're talking about patients at a lower risk profile, and 60% of the TAVI valves were balloon expandable sapien valves. The primary endpoint, well, we can be very short, any stroke at 72 hours, there was no difference whatsoever between the two treatment arms. So 2.1% in the sentinel arm, 2.2% in the control arm, and this in a trial with more than 7,000 patients. So I think that settles the discussion. We will not reduce stroke rates with the use of filter-based embolic protection, at least with the current generation of filters that we're using, that, as we all know, offers incomplete protection because the left vertebral artery is not protected. Also of interest, subgroups showed no difference, so there was not a sweet spot of patients who would benefit most, although we have to acknowledge that only 8% of the patients had bicuspid aortic stenosis. And also of interest, they looked at the calcium load of the aortic valve. It was considered to be severely calcified in less than 50% of the patients. And I think those are the patients that we would treat in our practice. So my main takeaway is, there is no data whatsoever to support an all-comer use of sentinel filters in TAVI. Well, partly because the risk of stroke is very low. It's less than, so the disabling stroke rate was only 1.2%. The any stroke rate was only 2%, so very low and very difficult to modify those low numbers. But I would still consider use of filters in heavily calcific aortic roots and also in bicuspid valves. Because again, as I always say, nobody is disputing that you will capture debris when you are deploying filters during a TAVI procedure. And why would you settle with debris in your brain? That still blows my mind. So I would still want to reduce it because maybe we are not covering or using the right endpoints. And that's another challenging aspect of neurological evaluations. How do you assess neurocognitive function and personality traits that may change after TAVI? So I think I would still feel comfortable if we would have the filters on our shelf, but probably use it selectively. Joost, what is your take?
Yeah, I mean, there are many things to say about this trial and about the concept in general. I mean, this is technology that was approved by the FDA by a single trial that actually failed to meet its endpoint, but just because of the concept. And as you say, the technology makes a lot of sense. Now we are 5-10 years down the line. We have now 2 trials with over 12,000 patients in which we found that there is basically no clinically meaningful benefit of deploying this type of filter in this number of patients. So that would mean, and I think David Cohen made some nice comments during the presentation, that you would need over 100,000 patients to show a statistically meaningful clinical benefit with endpoints in this incidence range. So that makes it, to me, very unlikely that there will be future iterations that will be studies in such high numbers of patients that are actually going to prove a clinically meaningful difference. That's one. Second, conceptually, so what is left clinically? Routine use, likely not. Obviously, bicuspid, heavily calcified disease, and patients that, for instance, undergo electrosurgery like basilicas and stuff like that, they may be still candidates in which it would make conceptual sense to use the device.
But we have a consensus, not for all people.
Absolutely not.
So then it becomes like a product like we also have in the coronary space. We use aspiration thrombectomy, we use rotational atherectomy, orbital atherectomy, but not in all patients.
That's it.
We select our patients for that. Same thing with the embolic protection, I guess. Yeah. Okay, so then we also have the 5-year data from the EVOLUT Low Risk randomized control trial. And this also was highly anticipated. Why? Because previously we already saw the 5-year PARTNER 3 data set that showed that there was no difference between outcomes, in terms of outcomes between TAVI with a balloon expandable valve versus surgery. This time we're looking at TAVI with a self-expanding valve versus surgery. And mind you, there was a prior presentation and also a publication in JACC where they looked at the 4-year outcome data. And basically what you saw in their primary composite endpoint of mortality and stroke, you saw that the curves were diverging more and more. So people were already assuming and making some statements that maybe the difference will be more and more in favor of TAVI, and maybe we should no longer talk about a class effect of TAVI, but self-expanding valves may behave differently than balloon expandable valves. So that is why the 5-year follow-up data was highly anticipated. Turns out that at 5 years there is no difference between TAVI with the self-expanding EVOLUT valve and surgery. So the composite of death or any stroke at 5 years, 15.5% versus 16.4%, and also no difference in mortality, although numerically you might still make the claim that the mortality of 13.5% with TAVI was somewhat lower than the 14.9% with surgery. Then, as expected, no difference in quality of life between the two treatment strategies, no difference in valve thrombosis. We are familiar with the fact that the hemodynamic valve performance with the self-expanding valve is superior to the surgical valve, but that did not translate in fewer hospitalizations or more re-interventions. The re-intervention rate was similar for the two strategies. We also had
at
more
5 years.
At 5 years, we also had more paravalvular leakage with TAVI, but at the same time we had more atrial fibrillation after surgery, more pacemakers with TAVI. So you see, each strategy has the pro and cons, but at the end, the hard clinical outcome is the same for the two strategies, and that makes TAVI as a less invasive procedure so attractive. So my main takeaway: there is no difference between surgery and TAVI, not with a balloon expandable valve and also not with a self-expanding EVOLUT valve at 5 years. And I also, to be honest, expect no difference at 10 years. I don't see any signals whatsoever to be worried about at this stage. So I think this is good news for the space. We are all moving to lower risk patients, to younger patients. I think it makes sense, but we also have to keep an eye on lifetime management, and this is part of the research that is still ongoing.
Absolutely. Also, to me, very, very interesting data and very supportive of what we're doing today, namely using TAVI in patients even at lower risk.
Okay. Then the TRILUMINATE Pivotal trial, we already were familiar with the 1-year data. This time the 2-year data were presented by Sable Carr, and this is also of interest. 572 patients were randomized in this trial to either tricuspid TEER or control. At 1 year, we already knew that TEER reduced the tricuspid regurgitation to less than moderate in the majority of patients, and the KCCQ improved by 12 points versus no improvement in the control arm. So, but within the first year, numerically, there were more hospitalizations with TEER. So that is why at 2 years, the results were quite interesting, because the annualized rate for hospitalizations for heart failure was lower with TEER versus the control. It was 0.19 versus 0.26 events per year. But I think the most compelling information comes from the control arm, because 60% of the control patients crossed over and received a TEER intervention after 2 years, after the first year of enrollment. And at the same time, we also have to take one step back. There was no effect on mortality between the two treatment strategies. So basically, the treatment of tricuspid regurgitation will not affect mortality. So 60% of the control patients, they crossed over after the first year, and they did that within, most patients, within the first 6 months. The mean average, or the average time, was only 89 days. So within 3 months, they had their valve treated. Why? Because they were so symptomatic. Because the group of patients that crossed over, those were the most symptomatic patients who also had the most severe tricuspid regurgitation and also had no improvement in quality of life. So those patients had a lot to gain from the intervention, and that turned out to be the case, because after the TEER, after the crossover TEER, their situation improved because their TR dropped to moderate or less in 80% of the patients, and their KCCQ started to increase with 12 points. And the annualized heart failure hospitalizations dropped again. Yeah. So you could see that they had the highest annualized heart failure hospitalizations up to 1 year, and then after the treatment, you saw that drop again. So I think this is quite a subtle indication that TEER does help and will reduce your hospitalization. So quite an elegant analysis by Sable Carr that was also published in Circulation. Also of interest, in the control patients that did not cross over, which was the minority, so 40% of the control arm did not cross over, they had very low annualized heart failure hospitalizations, although it was increasing in the second year. But also a significant portion of those patients had an improvement in their tricuspid regurgitation over time without the intervention. So my main takeaway here is tricuspid regurgitation reduction results or will result in less heart failure hospitalizations over time. Maybe not within the first year, but definitely after that. And there is a wide variation of phenotypes in terms of patients with tricuspid regurgitation, and we need to find the right patient for this treatment, and then we will make a difference. So I think it's time for reimbursement of TEER for tricuspid regurgitation also in the Netherlands.
Yeah, I totally agree. I think it's a therapy that now has proven to really make a substantial difference in terms of quality of life. Now heart failure hospitalizations is added to that. There is yet a lack of data showing a difference in mortality rates, but now with quality of life and heart failure hospitalizations, I think there is a strong case to get a more liberal use of the technology, and also in the Netherlands.
Yeah, and the crossovers in the control arm, this is what you see in all the trials. If you have device therapies with the control arm, if it's early TAVR, if it's TAVR unload, patients will start to cross over because they become more symptomatic. And these patients, the more symptomatic they are, the more their quality of life is affected. They will look for a solution of their problem. And yeah, there is no doubt that tricuspid regurgitation definitely is associated with symptoms and poor quality of life. Yeah. So okay, Joost, let's go to some coronary stuff. FAME3.
Yeah, so quite some interesting coronary trials presented. One was the FAME3 trial, of which Bill Fero now presented the 5-year results. So the final 5-year results of a trial that was conceptualized now 11 years ago to assess the to study the non-inferiority of FFR-guided PCI versus contemporary CABG in patients presenting with multivessel coronary artery disease. So basically 1,500 highly selected patients enrolled in 48 sites in a trial that then presented its primary endpoint to be actually negative. So PCI, FFR-guided PCI, proved to be inferior to CABG in respect to the primary endpoint of death, MI, stroke, and repeat revascularization. So that revasc is interesting because the 3-year data were presented by Frederick Zimmermann, who was one of the key investigators in the trial. And he demonstrated at 3 years, basically no significant difference in the hard clinical endpoint. So death, MI, stroke, and a pre-specified primary endpoint at 3 years. And that was exactly the endpoint, the final endpoint that Bill Fearon now presented at 5 years in a trial that actually had a group of investigators that managed to get 95% of follow-up at 5 years, which I think is truly remarkable and attests to the quality of the trial. But with respect to the endpoints, basically overlapping event curves with respect to death, MI, and stroke between PCI and CABG up to 5 years. Death rate similar, stroke somewhat higher post-CABG, MI somewhat higher post-PCI. However, repeat revascularization still twice as high post-PCI as compared to CABG, being a obviously softer clinical endpoint. Interestingly, Bill Fearon also presented some sub-analysis based on syntax score, and that was obviously low number, 500 per group more or less. But in the low syntax score group, we saw what we anticipated, PCI numerically better. In the intermediate group, CABG clearly better, but interestingly to me, in the high syntax score group, so those with syntax scores above 32, PCI numerically even better than CABG, so no difference statistically. But again, just to say, and that also brings me to the conclusion of this trial, PCI, contemporary PCI, is still a valuable alternative to contemporary CABG in patients with multivessel disease. In an era, I think, where the PCI results still are increasing, and that's also something the investigators demonstrated when comparing the PCR arm versus the PCI arm of syntax, which was performed 10 years ago, in which event rates clearly went down substantially in the PCI arm, in a trial that only used imaging in 12% of the cases. So I think there is still more to gain in the PCR arm, and with that, I think reassuring findings
absolutely
in these patients.
Absolutely, I think this is not a state-of-the-art PCI comparison. The fact that only 12% of the procedures had invasive imaging involved, that says a lot, and we all know that this is the way forward. But again, the longer follow-up data is of interest, and I also like the fact that we are separating the hard clinical endpoints from the softer endpoints, and then you really have to conclude that this is what you need to discuss with your patients, right? What do they think of a revascularization in the future, of some touch-ups, some PCI touch-ups over time? Yeah. Is it so bad? Is it such a big hurdle to overcome? Or would you prefer a sternotomy and a small but significant increased risk for neurological events? That's the patient that also has a voice in that discussion.
Yeah. Alrighty, RJ currently presented the imaging results of the ECLIPSE trial. So this is something we already elaborated on in the preview. So you remember ECLIPSE presented last year at TCT, studying the effect of orbital atherectomy in patients with angiographically heavily calcified coronary artery disease. In a randomized controlled fashion, 2,000 patients randomized 1-to-1 to either orbital atherectomy or standard of care using mainly non-compliant balloons, in a trial in which 62% of the patients underwent a imaging-guided PCI. So primary endpoint already presented, no difference in terms of minimal stent area, as well as in the primary clinical endpoint of being target vessel failure at 1 year, basically overlapping event curves, not showing any benefit of orbital atherectomy in these patients selected based on angiography. We anticipated, and maybe I hoped a little bit, that the investigators now would present some more granular data on how orbital atherectomy actually affected the calcium in these patients. And maybe that would have allowed us to tailor down a little bit on in which cases orbital atherectomy could have made sense as compared to balloons. That unfortunately was not the case. This was basically a sub-analysis presenting the outcome of patients that had imaging-guided PCI versus patients that had angio-guided PCI. And not surprisingly, 26% reduction in target vessel failure in cases in which a imaging-guided approach was applied versus angio-guided PCI. So that basically was the main message of the trial, very confirmatory of all the data that we've seen so far on imaging. So nothing new in my perspective. There were some debates on whether OCT was better than IVUS, which was in a univariable analysis the case, but disappeared after multivariable adjustment. So I would not draw too much attention to that. I think in this case, imaging was IVUS and OCT together, which in the respective uses led to a 26% reduction in TVF.
I must say that I don't find that comparison between OCT and IVUS very helpful, because we are using IVUS in a different patient population than OCT. Obviously, OCT is much easier to interpret, but there are some drawbacks with the contrast use, and the catheter is different from an IVUS catheter. The user friendliness, it's different. So that's one point. The other point is, I think orbital atherectomy is like a sentinel filter. You're not going to use it in everybody, and you don't need to use it in everybody. That is the main message from ECLIPSE. And now in this analysis by RJ, it's clear that you should be doing intravascular imaging. And that brings me back to FAME3. They didn't do any intravascular imaging. So can you imagine what would have happened if they would also have had introduced intravascular imaging? So that is definitely going to be the topic of future randomized trials, I bet.
Yep. ALTSHOCK 2.
Yeah, ALTSHOCK 2 was a trial evaluating an old friend of ours, intra-aortic balloon pumping. This was a multi-center Italian trial that was aiming for 200 patients, but was prematurely stopped after 101 patients were randomized to either balloon pump or treatment with vasopressors and inotropics. This was an interesting set of patients, and also the selection criteria were modified over time. Only 13% of the screen patients were enrolled in the study, so it is definitely a very selected group of patients, and they were looking for patients that were not suffering from an ACS, and they were also aiming for both ischemic and non-ischemic cardiomyopathy. So I think this is quite an interesting set of patients, but what they also modified is they also wanted to include patients in SKY B. So basically call it a pre-shock status. And I think this also, in my opinion, potentially was the sweet spot. You don't want to use a balloon pump in a patient who has a full-blown cardiogenic shock. Yeah. Probably you need more potent mechanical circulatory support. But in this kind of situation, especially if you enter the game early, then potentially the balloon pump might be quite effective. Well, this is what they studied. So they ended up enrolling 101 patients. The study started in 2020. And more than 50% of the patients had a non-ischemic cardiomyopathy. And treatment was started within 10 hours of symptom onset. This very early implementation of the mechanical circulatory support. 2/3 of the patients were on inotropics before study enrollment, and approximately 1/3 were on mechanical ventilation. So you have a patient that definitely is developing a shock. 28% were deemed in shock SKY B, 57% in shock SKY C, and 15% in shock SKY D. Elevated lactate levels in only 42% of the patients. So I think we are really looking at patients that don't have like the full-blown cardiogenic shock, but that, in my opinion, could have been the sweet spot of the balloon pump. And mind my words, could have been the sweet spot, because the trial was stopped for futility after 50% of the original 200 patients were enrolled. We did see some crossover in the control arm, but escalation therapy was rare, less than 5%. So now let's look at the primary endpoints. So survival or bridge to definite treatment or LVAD, so a transplant or LVAD at 2 months, was 81 versus 75%. So no difference between the two treatment strategies. The more interesting outcome was mortality at 2 months, less than 25% in both treatment strategies. That tells you that we're talking about a less sick patient population. So the shock was less deep than, for instance, in danger shock, where the mortality was more than 40% at 2 months. And also in IBP shock 2, the mortality was 40% at 30 days. So a different patient population. Still, no effect with the balloon pump. So I think it's going to be quite difficult to identify the sweet spot for balloon pumping this time. And I think even in the earlier course of shock, which I also believe to be the sweet spot, it's not happening there. And that also resulted us in stopping the IBP on time that we were running here in Rotterdam and in the lowlands. So unfortunately, I think it's a tough time for the balloon pump, and I think its destiny is to become a niche product.
Yeah, this is also to me painful. I think it's a technology that we have been using for many years with great effects on a patient basis in our routine practice. And this is not a technology that you can compare to a Sentinel filter, which is tested in 7,000 patients. No. And all these trials either stopped prematurely or selected the wrong patients or were simply enrolling for 10 years like danger shock in order to show something. So it's either investing a lot of money and a lot of time and a lot of sites in doing a trial that actually has the potential to show something, but all these small trials, I don't think that's going to make a difference. Although we have to appreciate the fact that everybody is still pushing and trying to do something in order to prove the concept.
But I think the value of ALTSHOCK 2 was that they were exploring patients earlier in the shock course. Yeah. And again, this also to me seemed to be the sweet spot for balloon pump. It turns out not to be. Yeah. Well, then you also have to accept it. Yeah. All right, let's go to antithrombotics.
Antithrombotics, 2 important Korean trials that we wanted to highlight. One was Yoo Kim, who presented the HOST-BR trial. So again, as anticipated, I wasn't sure what this trial was about. I thought it was some sub-analysis of a host idea. But this basically was another investigator-initiated multi-center study enrolling nearly 5,000 patients in South Korea. 1/3 with a high bleeding risk and 2/3 with a low bleeding risk. Patients that were then randomized according to their bleeding risk schedule profile. So in patients with a high bleeding risk, they were randomized to either a 1 versus a 3-month DAPT strategy, and those at the low bleeding risk were randomized to 3 versus 12 months of DAPT. Remember, in host idea, there was no difference between 3 and 12 months in a generic population. However, there was less bleeding in the 3-month cohort. So 3 months seemed to be the sweet spot based on host idea. Now, these Korean investigators did another trial of almost 5,000 patients to look whether there was a difference in strategies in patients stratified upfront in a high or low bleeding risk profile. So in those with a high bleeding risk, the 3-month strategy seemed to be better than a 1-month strategy. Less NACE, less mains, no difference in bleeding. So 3-month, the sweet spot. And in those at the low bleeding risk, randomized to 3 versus 12 months of DAPT, results were basically similar. So no differences in MACE, neither NACE, however, somewhat less bleeding in the 3-month arm. Again, 3-month being likely the sweet spot. So what do we have now? A trial with findings that apply to Korean populations. Most patients got clopidogrel, also in ACS setting, which is very typical for those regions, but not, for instance, for Europe or the US. 3 months seems the sweet spot, at least when you use clopidogrel in the majority. What else? 70% more events in patients at high versus low bleeding risk. So that is something we knew, but this trial nicely confirms. And then there was the discussion in the trial on which type of agents do you continue after the 3 months, either aspirin or clopidogrel. And that in this trial was left at the operator's discretion. So that's also a question that the trial did not really address.
But there was another trial that addressed that.
There was another trial that addressed that, and that was the Smart Choice 3 trial, which was presented by Joo from Samsung Medical Center, also in Korea. So this was a trial that aimed to assess the difference between either aspirin or clopidogrel monotherapy following 1 year of DAPT in patients at a high ischemic risk. So again, the question whether aspirin is better than clopidogrel was already addressed in the Host Exam Extended trial, in which clopidogrel proved to be superior to aspirin on the long run. This trial repeated that exercise, but then in patients at a high ischemic risk. And then again, guess what? At a median follow-up of 2.3 years, there was a significantly lower rate of death, MI, and stroke in those treated for the longer term with clopidogrel versus those on aspirin, 4.4 versus 6.6%, mainly due to lower risk of rates of death and MI. In bleeding, there was no difference, 3% in both arms. So in conclusion, results that mimic the host exam trial, enrolling patients in this case not selected based on bleeding or ischemic risk. So an interesting study advocating again, at least in a Asian population, the use of clopi on top of aspirin in patients that are continuing with monotherapy after 1 year.
You also have some remarks here. Did they do some genetic testing?
No, as far as I'm aware, that was not part of the study protocol that enrolled 5,500
And still,
patients.
clopidogrel outperforms aspirin. So, do we need to do those tests?
Yeah, that's an important topic that we also discussed in the preview. Yeah, I honestly think that on the long run, it doesn't seem to make a lot of sense clinically.
I agree. I think
the trial was simultaneously published in The Lancet, so more details are available there. But yeah, I think it's a lot of effort. And there's one argument, by the way. We're not testing aspirin response, we're testing clopidogrel response. Asians, like studied of course in this Asian or South Korean populations, are somewhat different. They react different to clopidogrel as compared to ticagrelor and prasugrel, in which they have a lot more bleeding. That's an issue that is not really the case in Western populations. So I would like to let's say, park the question maybe a little bit towards future research in the area focused on specific regions in which genetics are different.
And then in terms of the duration of antithrombotic therapy, of DAPT, I think I have a little bit of a different take, and it depends also on the patient that you're treating. But in the ACS arena, we are definitely exploring shorter durations of DAPT. We are part of the legacy trial where in an ACS population, we are dropping aspirin from the get-go. So only in the cath lab patient is on aspirin, and then aspirin is dropped and you give the more potent P2Y12 inhibitors. And then in Compare STEMI 1, we are dropping DAPT after 1 month in STEMI patients. So I think clopidogrel in an ACS situation, probably not. You want to prefer the more potent antithrombotic or antiplatelet therapies. But single or dual antiplatelet therapy, I don't think we have to separate the low bleeding risk with the high bleeding risk. I think also in patients with a low bleeding risk, single antiplatelet therapy might be the way to go, and this is what we're studying these days. All right, so let's go to colchicine.
Colchicine, yeah, Matt Buddha presented the EKSTROM trial, which was a prospective randomized controlled trial that aimed to assess whether treatment with anti-inflammatory therapy, in this case with colchicine, resulted in greater change in low attenuation plaque volume from baseline when compared to placebo in subjects with stable coronary artery disease. So low attenuation plaque, mind you, as assessed obviously by CTA. And secondary endpoints involving different kinds of plaque characteristics as identified on CT in a study that finally enrolled about 80 patients, which were one-to-one randomized to either colchicine or placebo, all stable coronary artery disease patients that underwent CT at baseline and 12 months. So the investigators demonstrated basically a negative trial, so no difference in low attenuation plaque, which was their primary endpoint. However, significantly less percent atheroma volume at 12 months in patients treated with colchicine versus placebo. Secondary endpoints, some small numerical differences in plaque types as identified by CT. However, they managed to find a statistically significant benefit in the occurrence of less dense calcium. However, again, 84 patients, small trial, likely underpowered to detect any meaningful differences in an area in which Colcott already demonstrated favorable effects on plaque stabilizations in patients with ACS in a OCT study. And other trials like CANTOS and EVAPORATE studying new anti-inflammatory agents like canakinumab or isocapentyl ethyl on having positive anti-inflammatory effects in patients with coronary artery disease. So a trial that is of interest, specifically because of the endpoint as assessed by CT. However, I'm not sure with this type of trial that this is really going to change the guidelines in terms of recommending colchicine for generic use in patients with coronary artery disease.
And how do we need to interpret this in light of the PCSK9 inhibitor trials and the statin trials that also showed some plaque regression?
Yeah, that's obviously a good question. Why? Because at first, a lot of these patients were already on statin. That means that if you want to assess the effect of colchicine, you need to assess the effect on top of statin. The same counted for PCSK9s, which conversely in large randomized controlled trials, both with imaging as clinical endpoints, identified or demonstrated an additional benefit. For colchicine, more or less the same happened in clinical trials, but in trials with imaging endpoint, perhaps a bit less less explicitly, so to speak. So yeah, there are multiple agents on the market. Obviously, we cannot treat patients with 6 anti-inflammatory agents. So at some point, I think we need to find a way to tailor the right drug to the right patient.
Yeah. Okay, let's go back to the TAVI arena with the DAPA TAVI trial. This was a study from Spain. More than 1,200 patients were enrolled, and the patients had a history of heart failure plus a depressed LV function or diabetes or a GFR between 25 and 75. The mean age of the patients was 82 years old, 50% were women, 41% had atrial fibrillation, and they had very high levels of NT-proBNP. After TAVI, 19% of the patients ended up having a pacemaker. Moderate PVL was present in more than 4%, so relatively high numbers. The primary endpoint was a composite of mortality or worsening heart failure at 1 year, and it occurred in 15% of the patients in the DAPA arm versus 20% in the control arm, and everything was driven by fewer heart failure hospitalizations. 9% versus 14%, and numerically lower mortality, 7.8% versus 8.9% in the control arm. So I think these results are definitely in keeping with the data of dapagliflozin and other SGLT2 inhibitors in the context of patients with systolic or diastolic heart failure. The interesting part is that now it's also demonstrated in elderly patients, because all the other trials were dealing with younger patients. These patients were in their 80s, in their early 80s, which is at least 10 years older than the heart failure patients that have been studied so far. So I think this is very helpful because most patients with aortic stenosis also have some kind of diastolic dysfunction. So I think this is a trial that might affect our clinical practice, and I don't see a reason why the majority of patients after an aortic valve replacement should not, at least for a certain time, receive an SGLT2 inhibitor. What is the downside? Well, you have a little bit more urogenital infections with this therapy, as is well known, and also a little bit more events of hypotension, but I think nothing that seems unsurmountable. So an interesting trial that probably will also affect our practice. And it is important to also think about medical therapy after valve replacement, and this is a nice example.
Well, I think that's a nice conclusion, and to me, it only supports the fact that we really should be have quite a low threshold in administering these agents also to patients post-TAVI.
And then the last trial that we wanted to highlight, and that is of interest to us, was the FAIR-HF2 trial. This trial is also published in JAMA. Stefan Anker took this on, presented this study of more than 1,100 patients with HFrEF, heart failure and reduced ejection fraction. Patients were randomized to a high dose of IV iron therapy or placebo. They had multiple definitions of iron deficiency, but patients could not be anemic. Turns out that the iron therapy resulted in a 20% reduction of the primary endpoints. So I had multiple primary endpoints, which were heart failure hospitalizations and also included mortality, but these reductions were not statistically significant. I think it's a play of statistics. 1,100 patients probably is not enough. So if they would have doubled the patient number, for instance, then probably this trial would have been positive. So I don't feel that we should discard IV iron therapy for now, not in the heart failure population, and also not, for instance, in the population of aortic stenosis, where also a lot of patients have iron deficiency. So stay tuned for that, because also in that regard we have some trials ongoing, for instance, the iron TAVI randomized controlled study. So with that, Joost.
Yeah, that brings us to the end of this wrap-up. A lot of things covered.
Yeah.
And we thank you for watching.
Thank you, and see you later.